delegates are invited to attend a Sorbonne workshop on anterior and posterior spine fixation in CMET Hall. With that, we now proceed to our next session on restorative neurosurgery. I would like to invite Dr. Tushar, Dr. Manoj Falak, and Dr. Sudipta Mukherjee to chair this session.
Presentation also. Right. I'm Sudipta Mukherjee. So you just load it in there?
No, you have to load it at the back.
This talk is not there. This talk is not there.
Okay.
And here Dr. Gopal will do.
Okay. So topic is same.
Yes. Thank you, sir.
Topic is different. Topic same address.
हाँ वो उन्होंने बोला मेरे को.
गोपाल को एक बार यार पूछ लो, कंफर्म करो. स्टार्ट करिए. हाँ, प्लीज स्टार्ट.
A very good evening to all of you. So we now come on to the next session, which is on restorative neurosurgery. And the first speaker is Dr. Sachin Kandhari. He is going to speak on epidural stimulation for cervical spinal cord injury. Welcome, Dr. Sachin.
So, good evening everyone. So I think it's the right podium and the right. So we just discussed neurological dysfunction in cervical spine injury and now how to proceed for the restorative therapy. I would like to limit my presentation in the paucity of time, but I would like to cover everything important. We all know the cause of spine injury and the load that the burden that we have in this country. The cervical spine epidural stimulation surgery, we are not actually trying to stimulate the spinal nerve roots. Our function is to actually restore the connectivity between brain and spinal cord and to use the excitability of interneurons and initially actively and then without any active intervention from electrical stimulation we want to achieve the movement pattern regeneration.
Dr. Sachin, you can adjust your mics nearer to your mouth. You will be clearer.
So the principle of the stimulation is one is automaticity, that spinal interneurons always have automatic patterns of movement that have to be revitalized. So that residual connectivity from the supraspinal portion always has to be there. That means whenever we operate, the spine has to be anatomically intact, maybe in part, but they cannot be complete disconnect from the spinal cord, no complete transaction anatomically. Functionally, it can be complete transaction. And then once we induce the plasticity changes, then we have to go by activity-based rehab therapies to make the network more excitable with a lower level of stimulation. So looking at this figure, when we stimulate the spinal interneuron networks, they start getting activated, proprioceptive inputs and activity-based pattern, and then we can see there's a connectivity restored between the brain and the spinal cord. The automated spinal cord, it controls the posture and locomotion of the upper limb. It helps to generate the complex activity pattern. We are not looking at a simple one muscle movement or random movement of like an FES, but at a complex activity pattern. And this is one major role is played by supraspinal connectivity. So unless there's a direct communication between brain and spinal cord, so we cannot have a volitional control of the movement. And then most important is once you get a movement pattern, you have to strengthen the pattern, because initially when the stimulation is on, only then you will perform a movement, but over the time the network becomes so excitable with easily you can switch off the stimulation and then do it. So in this procedure, in this figure we have tried to cover, in all these cases we try very high cervical injury like C4 and above. C4 we do take in consideration, but implantation is done from C4 to T1 or T2. We want to have some truncal supply, we want to cover all the movement patterns from shoulder up to the fingertips, And the lead is around 6 centimeter long, and it's enough to cover from C4 to T1. Then we have different subgroup patterns for stimulation of different muscle groups, like for shoulder, extension, flexion, for elbow, wrist, and the fingers. So over the activity training, you find the patterns of the stimulation that is able to achieve the movement in one muscle group. Then you keep practicing on that. So these are results that we expect. Voluntary movement of the upper limbs, muscle mass growth, and autonomic dysfunction is improved, and sensation becomes better. So who qualifies? All subacute and chronic traumatic spinal cord injury patients. We wait for at least 6 months to allow for the spinal shock to settle away and natural recovery to occur before we proceed with epidural stimulation. In this group, we have taken only the cervical spine injury patient, previously presented a lumbar spine last year here. And both complete and incomplete qualify for this. And no active infection, no bed sores or inclusion criteria. Pre-op, you do one detailed evaluation, MRI to rule out the complete cord transaction. In case you have doubt on the simple MRI, we go for tractography. There has to be some residual connectivity maintaining there. EMG to evaluate whether what muscle function is acting or there's some support from the upper muscle group producing a Fox movement in the lower muscle groups. Intra-op, we check for the lead position, and intra-op surface EMG, we stimulate the cord and we see for the movement patterns. If we get the movement patterns, only then we implant the stimulator, otherwise we don't do that. So this is how the array will look like. It's a 5-6-5 array, because we want to have a good current supply in the middle extending to laterally so that all interneurons in the middle can be excited. Some people have tried to use 2 bipolar leads, but in our opinion that doesn't work that well. So what do we gain? Arm and hand strength immediately upon activation of SCS. See, this is what we call as active intervention. When you stimulate and the muscle groups respond and the interneuron respond, that is the active phase of it. Over the time, you don't require the stimulation to be on. People can move the arms and legs without doing that as well. Why I said leg, I'll come to that point as well. So in this study, we have taken 10 subjects. The mean age was 42.5. All cervical injuries C4 to C7. Subacute and chronic, the mean time was 3 years and 4 months. Outcomes were measured on MMT scoring, muscle girth, Fugl-Meyer assessment scale for cervical spine injury, and Asia scoring. In key findings, so we have shown the results in 2 parts. One is when you stimulate the spinal cord, and then how much the improvement is, then is without stimulation as well. In every muscle group, even without stimulation, that is, if we switched off after some time, you see some improvement in the muscle group activity. Muscle girth increased in every muscle group. In Fugl-Meyer is the most interesting improvement in this. Upper extremity from 9 to 19, wrist, hand, and the most important is that we are able to get the fine motor skills back as well, which is the most challenging part in cervical spine injury. Asia scoring with the stimulation being on, increase in every muscle group. So this is case of C56. He had paraplegia with quadriparesis, with upper limb paresis. So this is before there was no shoulder movement and only some flickering movement in the upper limb, in the fingers and wrist. Just immediately after the surgery, when we start stimulating, you can see that tablet there, we see the improvement occurring. And day 5, activity-based training, stimulation on. It's a complex movement pattern and not just one muscle group, moving there. In 1 month, we were able to make him quite independent. Look at the truncal control as well. Why we want to go to T1 and T2? Because we want to stimulate the thoracic interneural group for the truncal recovery. This writing is day 5, day 15 and day 25. This So he's gone 13 years. And after 5 years, we operated upon him. Interestingly, in all these patients, we have observed even lower limb improvement when stimulating with the cervical spinal cord. So that's a very clear evidence that what we are doing is not only stimulating some nerve roots or just trying to work like an FES system. Actually, it's very important. This video is just to exhibit that changes can be, induced as early as day 1. This is day 1 after surgery. As the complexity of the movement that we practice increases, the individual muscle as well as the movement pattern gets strengthened over the time. Is 18 years old injury, so a swimming accident at the age of 12. I guess that video is not playing somewhere. This again, how we can achieve this movement is in day 2 after surgery. Previously there's no movement in the finger and the wrist. And no trunk control. In 5 to 6 days, we're able to get him to good trunk control. Thank you.
Dr. Sachin, any other center which is being done or any
So
bigger
actually,
study?
The cervical epidural stimulation has been mostly tested for respiratory function. So in our center, we divided them into higher cervical and cervical stimulation. So higher cervical we do only for respiratory and shoulder movement, and that we do invasively and non-invasively as well. As of now, we have a patient from AIMS with us. She was here for 8 months. Now we are doing non-invasive stimulation for her respiratory control, and we are going to present on that next. And very few studies have been published for the cervical epidural for the functional recovery. So in my knowledge, there are only 3 to 4 studies published as of now. Our work will be published in this in June or July. We already compiled the data. And we are not aware of many centers doing cervical epidural. Dorsal lumbar epidural, yes, now in all over it's being done quite actively.
Okay. Any other?
The lead cost depends on whether you use a non-rechargeable system or rechargeable system. So, and to that effect also, if we can do this all non-invasively, the cost comes down heavily. In rechargeable system, the device cost goes up to 10 to 11 lakh because the battery life is 9. So we have to see that the pain device cannot work in this. Current requirement is very high. We stimulate in 2 patterns. One daytime for the activity training, and there's an overnight what we call a resting current. So that is a low dose current, low frequency current, which actually helps in regeneration. So the battery consumption is very high. If we, at the time of surgery, we get movements at very low potentials, we do offer a non-rechargeable battery which has a battery life of 4 to 5 years. And with very high usage, it can go down to 2.5 years. After that, you have to change the pacemaker. So that device is cheaper, say 6.5 lakhs rupees. I'm talking Medtronic here.
No company in India is
No, no, sir. So we tried one company. So we tried exercising that power.
Our computer engineers are best in the world.
So we contacted one company in Chandigarh and we gave them the technical know-how and input. And then he got some contracts through us. And then he went to that country where we were trying to do that deal with, and he made an import contract instead of manufacturing. And then COVID came and they left the field altogether. So even DVS device, these devices are very simple to make. Now we have contacted one OEM in Germany because the main deterrent is the cost.
Why
You know.
I'm telling, if you manufacture outside India, the cost will go up.
It can be made here. So OEM can give us technical know-how. The same can be done here. But we are mostly traders, not very few people can. To address that issue, only the next present is on the non-invasive stimulation. So in cervical, if we can get good result non-invasive, so invasive we can reserve only for the complete injury. If there's some movement present, then we can easily go with non-invasive only.
1994, we had a conference in Bangalore. We went to GE, we went to Philips, we went to Siemens. We asked them why they are manufacturing in India. They said cost will come down so that we will have big Indian market. After so many years, we are not being able to manufacture.
So first-hand information is that few top scientists from USA, they went to Medtronic for on-label indication for spinal cord injury, but they refused that it's not a very big market for us and pain is a bigger market for us. So that's why. So all this is being done under off-label indication in the name of pain. And we need to have special devices modulated for the use in spine injury with special lead designs. Now it's by chance that the lumbar segment is, the L1 to S1 root area is 62 millimeters, and the device, the chip length is 65 millimeter, and the width is 1.1 centimeter. That by chance is fitting into that. Otherwise, this would not have never happened. So it's by default, but special lead need to be designed. We have thought about a lead which would have higher stimulation in the lower part, then 2 wires going up to the thoracic spine, because trunk control is the most deterring factor in recovery. You stimulate dorsal lumbar spine, you get good movement pattern, locomotor pattern, but the trunk control always. In same way with cervical, we want the leads extending downwards till T6, T7.
Thank you, Dr. Sachin. May I now ask Dr. Parag Gode for his presentation on non-invasive spinal cord stimulation.
Hi, good afternoon, good evening, everyone. So before I start, I have 3 disclaimers for everyone. I am probably the only non-doctor here. So I am a scientist. Thank you. Second, I'm a scientist by training. I trained at UCLA, University of California, Los Angeles, did my PhD in engineering, bioengineering. The second is everything that I'm going to show here is in the chronic injury stage. So in individuals 1 year and post, or in the case of stroke, 1 year post initial diagnosis. And third, the overall objective of what the work I've done in this area is primarily to restore function and to improve function. This is not new to you all. Spinal cord injury is probably the most traumatic condition that an individual faces. But the bottom line is that every single organ system that I pointed on the right is impacted by the trauma. Now, the key to all that I'm going to talk about, and in extension to what Dr. Sachin talked about, is the spinal cord is smart. And what do I mean by that? Here's an example of a dinosaur known as the iguanodon, which is about 300 tons in weight. And what you see on the right side is the size of the brain of the dinosaur, which is the size of a small peach. So imagine 300 tons of muscle mass to be controlled by neurons the size of a small peach, probably smaller than my left fist. That's primarily because of the intense amount of neurons that are present in the spinal cord. Now, this is a video of one of our early rats from UCLA back in early 2000s that had received a complete spinal transection. And we are testing the ability to step on a treadmill with a body weight support in the absence and presence of lumbosacral epidural stimulation. So an extension of what Dr. Sachin talked about with the epidural stim. So here you can see rat unable to take steps, and the moment you turn on the stim, the rat is taking steps. Now, in this particular case, the pattern of movement varies depending on how you stimulate. These are just 2 simple wires. implanted over L2 and S1 spinal levels, and the moment you turn it on the stimulation, you're able to generate these complex movement patterns. What we have figured out is that we can do this non-invasively. That's where we see SCONE, spinal cord neuromodulator, which is the device that I've developed. We place specific hydrogel electrodes. These are off-the-shelf hydrogel electrodes over the lumbosacral spinal cord. Complete the circuit by placing ground electrodes over the iliac crest to activate the spinal circuits. Now there are a couple of different aspects of this that you need to understand. The overall mantra here is that we want to activate the spinal neurons in such a way that it is able to reconnect with the brain. And when reconnection occurs, all the movement patterns that you observe are voluntarily connected. So the way I like to describe it is it's an external pacemaker for your spine, in addition to being a hearing aid that allows communication from the periphery to the brain. And I'm going to show you an array of different studies that demonstrate the improved function with SCONE stimulation. Here's an individual with an incomplete spinal cord injury attempting to eat, and on the first day, in the absence of stim, he has to go to the food, whereas on the same day when the stimulation is turned on, here we're stimulating C3, C4, C6, C7 vertebral levels. When stim is actively delivered, he stays in his place and the food comes to him. He then received training for 30 days, 5 days a week, an hour a day, and at the end of 30 days, you can see more fluid patterns of movement, more effective, faster overall functionality, and an improvement in quality of life. So I'm going to show you an array of different studies ranging from upper extremity to trunk function, individual with chronic SCI, Asia C, C4, 7 years post-injury. Here we're stimulating the T11 vertebral level, and as you increase the intensity, he's sitting on a little forced platform, and we're monitoring the center of pressure on the right hand side, and you can see the deviation occurring as his body posture changes, reaches a certain threshold, and that's when you see upright sitting induced by the stimulation. And we use a certain intensity for active training over a period of time. Independent standing, again, chronic T4 Asia A in the presence of 3 sites of stimulation over. And again, we undergo dynamic standing, where he's standing on that particular force platform and attempting to make a plus sign using his body weight support and shifts in his body weight support. So playing basketball-like game with this particular activity-based training modality while actively receiving stimulation. Voluntary movement, an individual with T9 Asia A, about 5 years post-injury, initially being asked to flex his left knee in the absence of stimulation and is unable to do so. We turn on the stimulation over his lumbosacral spine. Now here again, the key is that the stimulation is not inducing any movements. There are no muscle MEPs that are observed in any of his abdominal or lower extreme muscles until he starts to make a voluntary attempt. He's given the cue, and it takes him about 4 to 5 seconds from the point of cue to actually successfully maneuvering his knee up to his chest. And that's the time that it probably needs for the neurons, the command to go from the brain all the way down to his lumbosacral spine to activate the right muscle groups. We've also tested this in combination with robotic stepping. So in this case, an exobionics unit from this is the same individual whose voluntary control that you just saw, essentially showing that technologies are not in isolation. They are all synergistic, and you're able to combine them to observe a more global impact. Present in the while current is being actively delivered, but also in the absence of stimulation. Here's an individual with an Asia A C5 injury, able to eat after about 6 months of stimulation, even in the absence of active stimulation. Now this is all of the motor functions. Here are a few examples of autonomic functions changes that we have seen. Individual with chronic SCI 10 years post-injury at C5, we're looking at his improvement in breathing function while actively receiving stimulation, and as you can see, when the stim is delivered over the C5, C6 vertebral levels, the ability to breathe, his overall volumes are better. After about a week of stimulation, he was actually able to voluntarily cough while in a supine position. here's a quick video of changes in bladder function. Individual with T4, Asia A, receiving stimulation for the first time. As you can see, the contractions in his muscles that are being induced by the stimulation. What's more important here is that about 10 seconds before active voiding, and you can see the stream of void there, he actually reports that I am going to void now. I'm reaching a point of voiding. And that restoration of sensation is just as critical as the actual output that you're observing. This is video from Sachin's clinic here, looking at sit to stand. The ability to actually maneuver from sit to stand is just as important as walking. And the impact in individuals with chronic stroke. And this doesn't like me, never mind. We've expanded out the indication to individuals or children with cerebral palsy, which is the most prevalent sensory motor dysfunction. Here's a child with level 4 CP attempting to walk on a treadmill, and on the same day when we delivered active stimulation over his lumbosacral spine, he's able to successfully take these steps. Again, the stimulation is not inducing any movements, the stimulation is only exciting his nervous system to a point where he is able to voluntarily take these steps. Individuals with level 5 CP that have also impaired trunk and head function, on the left in the absence of active stimulation versus on the right when stimulation is being actively delivered. Here the mom is only positioning the head such that she is able to then attempt, and when she releases, the child is able to actually hold her head up on her own. But more importantly, you can look at the overall posture being calmer and a more better posture that she is demonstrating when the stimulation is being delivered. And when you perform this over a period of time, here's a child again with a level 4 CP attempting to being trained to walk on a treadmill. When he received therapy twice a week, an hour a day, at the end of 4 weeks, he had regained some voluntary function where he's able to take steps, a few steps on the treadmill. And that continues to improve after 8 weeks of therapy, where he's now completely voluntarily able to take these steps. But most importantly again, that the improvement function is not present only when the stimulation is being actively delivered, but is sustained even in the absence of stim at home. As you can see here, the child in the walker before versus after at home after just 8 weeks of training or 16 hours of stimulation, being able to take steps voluntarily, which he could not do earlier. So what's next? We are looking at a few aspects here: sensory motor function, autonomic function, but as I said, all of these other aspects are impacted by spinal cord injury or stroke or MS, sexual function, which is one of the highest priorities for some of these individuals, temperature regulation, cardiovascular function, spasticity, and we know we can potentially impact all of this with the basic underlying principle that the spinal cord is smart. And expanding thus out to other indications, including Parkinson's, MS, traumatic brain injury, as well as stroke. And with that, I'd like to thank you for your time. Happy to answer questions.
It is not like transcranial stimulation, magnetic stimulation. You can have transspinal magnetic stimulation.
We can do magnetic stimulation as well. The difference being the magnet is a lot larger, so the specificity
You
that
can design smaller magnet with more powerful magnet. Why you want a bigger magnet anyway?
portability. Magnetic
It's all possible. You
It is
can-
possible. I'm not denying it. At this
Fast computer
At
in
this-
1932
Sure.
was one hall.
At
one
this
room.
current stage, the technology for magnetic stimulation is not portable. We need to develop new ones. I'm an electrical expert. I built electrical devices. Magnetic stimulation is absolutely possible. You get smaller devices, so it's for pain management and other indication of sleep management. There are magnetic devices. It's just not an area of interest or expertise of mine.
But you have to collaborate. Everything cannot be one man's expertise.
So Parag, what is the difference between complete paraplegia or complete denervation and partial, like results between the two?
So overall, when you say complete, do you mean functional or anatomical?
Functionals.
So functional, so the probability of success is, or the magnitude of success is directly proportional to the level of functionality at baseline. So incompletes definitely show larger improvement in absolute numbers compared to complete individuals. However, individuals that have complete injury also respond. It's just it's proportionally smaller just because of the severity of the injury. The word complete is in fact one that we are fighting against and want to change it to discomplete, because so far in about 250 odd SCI individuals that I have personally worked with, we haven't found a single individual that has been anatomically complete. They're only functionally complete, anatomically incomplete, because of the voluntary function that we've been able to restore within the first day.
Great.
What is about mantra therapy?
What?
Positive vibration and positive vibration stimulates the immune system.
Correct.
Anything you have tried with positive vibration?
So we've
mantra therapy?
absolutely. So we've done two different studies. One with vibrotactile stimulation of the base of the foot. This was actually developed by the Russians for the space program, where they would stimulate the base of the foot to imitate walking in space. The other study, again by the Russians, in collaboration with us, was where we stimulated large muscle groups over the lower extremities to see if that can induce walking-like patterns. And yes, they absolutely work. Both of those are directly linked to activating the same networks in the spinal cord. So activation of the base of the foot, vibrotactile stimulation, muscle vibration stimulation, are synced and they activate the same networks in the spine, and when you combine that with electrical, you get a much larger output because the synergy exists. So again, those are all technologies that have to be developed, should be developed, and we really hope that more engineers start building these medical devices, because we know that they all, from an overall neurophysiological standpoint, have a common source in the spinal cord.
Any microchip developed for the microchip? See, for example, in the MIT, somebody developed artificially,
Yes.
and they had about 25,000 chips for stimulation of the hand movement.
Yes.
But they could not develop chips for the wrist movement. So what is about the microchips implant?
Correct. So our team actually at UCLA was the first team to develop the most advanced electrode array for stimulation of the spinal cord, including the electronics to control it. So that is the next generation chip that needs to be developed. We had about 1,064 channels that we would electrically stimulate the spinal cord, cervical or lumbar.
Thank you, Mr. Roy.
Thank you.
Thank you. I now invite Dr. Gaurav Sharma. He is going to speak on brain-computer interface.
Good evening, everyone. So today my topic is brain-computer interface. Brain-computer interface is a system that determines functional intent, the desire to change, move, control, or interact with something in your environment directly from your brain activity. In other words, BCI allows you to control an application or device using only your mind. So brain-computer interface provides a new communication channel between your brain and a computer, so that you can use your mental activity involves in electrical activity, and these ECG signals can be detected with techniques like ECG or ECOG. BCI technology can be used as a tool to assess the remaining cognitive functions of these patients. BCIs are useful to use for motor rehabilitation for stroke and brain mapping procedures. So there are three main parts of brain-computer interface. First is device that measures the EEG signals. Second is computer that process and analyze the raw data from the EEG. And third one is an application that sends signals to the command. So for example, if you want to switch on the lamp, we have to decide to turn on the lamp, then execute, reach out with your arm and fingers and switch on the device. Then output is lamp is switched on. In BCI, we plan, we decide I want to switch on the lamp. Then this EEG signals goes to the computer system, BCI system, that rectify that signals and send the command to the output, for the output, that then the lamp will switch on. The main part of BCI is feedback. The system must somehow let the user know that decision or intent action the computer was able to interrupt. It is mainly useful for the relearning process in neuro rehab. So this is another example with feedback. BCI, uses of BCI in neurorehabilitation. Originally, it was designed to help the people with locked-in syndrome to communicate with other peoples. Now, BCI is using BCI now being explored as a means to drive power wheelchairs, some exoskeleton, prosthetic limbs, and way to administrate neuroregenerative devices like FES to regain the muscle power. So there are some devices which are those are available in the market for neuro rehab. So first one is Recovery CAX. This device from Austria. It is the first rehab system for a stroke patient that pairs mental activities with motor functions. A neurological disorder might inhibit ability to move hand, arm, and feet, but may not be the ability to imagine the movement. So it is a unique combination of three patterns. Like first is motor imagery. Motor imagery is imaging to move a hand or foot. So recovery device catch those signals when we imagine about the movement. Then virtual reality. In virtual reality, there is a simulation on the screen that show you a motor task which you want to perform, like you want to move your hand or foot. Then third one is FES. With FES, there are two electrodes placed on your arm or foot on the legs. If the system recognizes a correct motor imagery, the muscle get electrically stimulated, causing a real movement. So there is short video.
You had a stroke and now suffer from limited mobility, hemiplegia, or pain due to spasticity and tremor. But physiotherapy, occupational therapy, and other conventional therapies aren't helping you. Try Recoverix. Our innovative stroke therapy combines 3 rehabilitation methods to help your brain learn new ways to move your fingers, hands, arms, and legs. The first step is to imagine movement. If your hand is impaired, for example, you can imagine waving at someone. Meanwhile, Recoverix measures your imagined movement using an EEG cap. This movement is then simulated on the computer screen by a virtual avatar. This gives you the impression of actually moving your impaired arm. At the same time, your impaired muscles are electrically stimulated in real time, resulting in real hand movement. Across 25 training sessions, we imagine your movement a total of 6,000 times. It's about as many times as it takes a child to learn to walk. This combination of motor imagery and real movement execution is the key to Recoverix's success. It is never too late for a Recoverix therapy. We've helped patients 10, 20, or 30 years after the stroke.
And the second device is IPSI hand. This is the first FDA cleared device leveraging brain-computer interface technology to assist chronic stroke patient in rehabilitation. The device utilizes your uninjured side of the brain, ipsilateral side of the brain, to improve arm and hand functions. So the principle is same: connect, train, and enforce. Connect from EEG signals and training, and reinforce with the stimulation. There are 3 components of this device. First is headset, wireless EEG electrode headset that catches the signals. Then there is a hand function, hand exoskeleton that start your movement, flexion or extension. And there is a tablet that combine both the devices, headset to exoskeleton, and give you feedback of the movement. Thank you.
Suppose you are careless one side, half your motor cortex work other side. At any given time, only 60% motor neuron of cortex work. So you have large number of motor neurons never work. So if you utilize it, taking their stimulus to opposite side, same side. Any idea? My question is that you know that you have motor cortex. It has millions of neurons. Only 60% utilized at any given time to have a motor. 40% is never utilized. They are recruitment only when they need. So those 40% can be utilized for paralysis side. Have you ever thought about idea? That is not the concept. So you should, that is neuroplastic का वो नहीं रहना. Otherwise they will not come to you. They will not come. It's that simple that everybody has neuroplasticity, both sides should recover. So even though we have been talking forget about upper motor control. So forget about brain. You stimulate the anterior horn cell to make that functional. That is what spinal cord implant is all about, right? So why can't be done?
That's what we have. So in that what you're talking anterior horn cell, that is exactly the BCI for recovery is discussed.
So you are in the prototype you are developing.
Easy command is FES. Easy command for movement and FES to execute the movement that anterior horn cell. When we talk of spinal cord implantation, that is for the circuitry and not for one muscle group. That's what
That is a big one muscle.
So but this is approaching from brain by the EEG and the output by FES. Instead of FES, we can add NMES or even spinal cord stimulator device to better communicate with the brain. That will be like a brain Wi-Fi you electrode.
Almost 25 years back, Dr. Kano and Kato came and put a spinal cord stimulator.
Yeah.
And they had a bladder stimulator also. Did a pacemaker for the bladder. So you should have pacemaker for the spinal cord.
Yeah, absolutely.
So we come on to the next topic. Dr. Amandeep Kaur, she is going to talk on dental trauma in boxing. It's a knockout. It's an interesting topic.
Why boxing? Why not civilian? You are blaming the boxers.
Respected chairpersons, seniors, colleagues and friends, a very good afternoon. For the next 10 minutes, I'm going to shift gears from traumatic brain injuries to traumatic dental injuries. About 90% of all maxillofacial injuries are traumatic dental injuries. Now, this refers to any injury that takes place to the tooth and the surrounding tooth structures, like the periodontium, and the gums, periodontal ligament, alveolar bone, and soft tissue such as lips and tongues. According to Lancet, traumatic dental injuries, they comprise 5th most prevalent disease in the world after dental caries, iron deficiency anemia, tension type headache, and age-related hearing loss. About 71 to 92% of these traumatic dental injuries, they occur before the age of 19 years. And about 15.5% of adolescents, they suffer at least one traumatic dental injury affected permanent tooth in their lifetime, probably because this is the age when they're going out and they're involved in a lot of outdoor activities. So this is the number that we have, and this is a number that we cannot ignore. About 223 to 303 million children and adolescents across the globe are affected by some kind of traumatic dental injuries. Now, the cause could be anything under the sky. But when we come to sports, the sports-related traumatic dental injuries are immense. That is something that we see on a daily basis in the OPD. So the American Dental Association and the International Academy of Sports Dentistry, they recommend using mouth protection for almost 30 activities, whether they are contact sports, non-contact sports, or minimal contact sports. And this includes a helmet, the face masks, and the mouth guards. Right now, what's available in mouth guards in the market is the Boil and Bite, the stock mouth guards, and the customized mouth guards. Now, as Sir pointed out, boxing, because I am coming from the land of Mary Kom, I'm from Imphal, so that's the place where she is, and that's why a lot of people, youngsters, are involved in boxing. And I see a lot of cases where students, children, kids, they're involved in boxing and they land up in the dental OPD with some kind of injury. So I thought it would be interesting to focus on one particular sport. And also interestingly, boxing is the only one of the very few sports where intentional force is applied to the opponent as compared to other sports. So this was just last week when I saw this patient. Again, he's not wearing a mouth guard, and the injury, the right central incisor is a complicated crown fracture, but the left one was totally out of the socket. It was a valve tooth. So when I asked the patient whether he has the tooth, he didn't bother. He said, I didn't bother to pick and look for it. But if he had the tooth, maybe I could have helped him and replaced it back into the socket. So that's another thing that I'm trying to work on and create awareness in that part of the country. So the spectrum of injuries that we come across is huge. It could be like a simple or uncomplicated crown fracture to the more severe types like complicated crown fractures and complete avulsions. So when we did this, a very simple study, preliminary study, this was done in collaboration with NIT Manipur, where we tried to study the 3 most common punches that are used by boxers along the X, Y, and Z axis. So this is a cross punch, this is along the X axis, one with wearing a mouth guard and one without a mouth guard. So this is a jab punch, which is across the Y axis, and the uppercut is along the Z axis. So when we study the displacement, as we can appreciate here, is the movement of the mandible in response to the impact force. So we can see that the displacement is not as much as compared to the other punches which we'll just see. So here the force is transmitted to the skull in the jab punch and in the uppercut punch. So when the same simulation was run with the mouth guard, again we studied the 3 punches across the X, Y, Z axis, cross, jab, and the uppercut. And again we studied the displacement, and we can appreciate that the amount of displacement is less as compared to when the player is not wearing a mouth guard. So this is with the jab punch and the uppercut, and this is the principal stress. And as we can appreciate, the first picture is without the mouth guard, and the maximum force that can be transferred is about 32 megapascals, but in case of the mouth guard, it's reduced to about 28 megapascal. So what's the roadmap ahead? We're trying to work on 3D printed mouth guards. There's so much going on with 3D printing. This is an ongoing project that I'm doing, and we're trying to test different materials. This is the one we're working with PLA. This is the STL file format. I'm trying to design a different design of the mouth guard as well. This is just 3 days back before I flew. This was printed that day. Food for thought. I would like to end with this. Interestingly, in 1984, the International Boxing Association, they made it mandatory for the Olympic boxers to wear a mouth guard. But in 2013, the International Boxing Association, they've now prohibited the use of head guards for the boxers. So this is a very recent systematic review that points out that it's well known that the head guards, they protect against lacerations and skull fractures, but how effective it is against concussion and other traumatic brain injuries, we do not have enough evidence on that. So this is something that needs to be taken with a pinch of salt, and we do need to generate more evidence to say whether the boxers should or should not be wearing a mouth guard. With that, thank you very much for your patient listening, and this is, okay, it's not, this is a very rare flower. It's found only in Ukhrul district of Manipur. It's known as Shiroi lily. You can Google it and see why it's rare. And whenever you happen to visit Northeast, please check this out. Thank you very much.
I think you should have shown about tooth implants. Those tooth falling off. Why I'm asking, 23rd of July 1993, I had an accident.
Okay,
2
sir.
of my tooth came out. I took it to Dr. Kharbanda.
And that was Sunday. So he went to implant it. And it went on for almost 15 years. So if a tooth fall off, whatever reason may be, boxing, accident, whatever it may be, take it to a dentist and implant it.
Yes, sir.
We sometimes think artificial tooth is better, but always natural is better.
Better, always. Sir.
So loose tooth can be implanted like anything implanted. So my tooth, what Dr. Kharbanda did not write, it would have been a case report, I'm sure. How long is the average tooth survival after implant?
So actually it depends, sir.
What is 5 years survival, 10 years survival, and 20 years survival?
So actually, according to the latest IIDT guidelines, it's the extraoral dry time that's important. So it's, if it is reimplanted within 15 minutes, that's a platinum time. So with the PDL fibers, they are viable. Between 15 to 60 minutes, they are viable but compromised. And if we do the reimplantation after 60 minutes, they are compromised. So then long-term complications are there.
Percentage, that is all, everything is like that. If you have kidney, anything which is done certain time, I'll better survive. Also common sense there. Percentage.
Sir,
No data.
yes, sir.
Don't laugh. You say, everything that. Best answer, nahi? I always say exam candidate, I don't know the best answer. Because the next question you will ask. Nahi? Okay, thank you.
Thank you, sir.
Thank you, Dr. Man. I call upon Dr. Suman Jain. Topic is therapeutic efficacy of patterned transcranial magnetic stimulation in spinal cord injury, a new ray of hope. Welcome.
Respected chairpersons, Professor Mahanta, and all the delegates, good afternoon, everyone. I'm going to talk about a topic about which I think we have been discussing for last half an hour, TMS. So this has been said, that already said, spinal cord injury is very, very prevalent in India especially. You can see that red, green, dark green color, that India, the cases annually which are coming are very, very high as compared to maybe the USA and other countries. And most of the affected population is males within the age group of 20 to 49, which is actually the productive age group. What are the challenges basically in spinal cord injury is that definitely there is, after primary impact, there is a loss of neural connections, but like it's been said, that there is a secondary damage which spreads both rostrally and caudally, and gradually over a period of time there is activation of glial cells and there is a formation of scar within, in humans especially it takes about 4 to 6 months. And this scar is actually, once the scar is formed, it not only is a mechanical barrier which can prevent any sort of neural repair and regeneration, but also secretes a lot of inhibitory molecules. And therefore, if there is any repair going to be happen, that doesn't happen because the environment has become inhibitory. And therefore, we need to have a strategy which can, has a multi-pronged effects and therefore can provide everything. It can replace the dead cells or prevent apoptosis. It can prevent the expansion of the initial damage, promote axon regeneration, attenuate gliosis, and therefore the scar formation. And therefore, now we are proposing transcranial magnetic stimulation. So as a physiologist, before we moved on to so what is transcranial magnetic stimulation? It is actually started in 1985. It is one of the most recent and accepted strategy, which is non-invasive neuromodulation strategy. It works on the principle of electromagnetic induction, which was given by Faraday. So what he says is that when you pass the current through the coil, then the magnetic fields will be generated. Now, advantage of using magnetic fields is that they can easily penetrate through the skull, and therefore once they reach the neural tissue, they'll generate eddy currents. And the neural tissue is working on the phenomenon of that, what is the current, what is the potential changes, what is the potential differences. And therefore you would expect that if you're stimulating, say, the motor cortex, as in this case shown in this diagram, then you'll be stimulating the descending tracts like corticospinal tract, and therefore you will be modulating activity through the areas through which the corticospinal tract is passing onto the spinal cord and also affecting the muscle tissue. So, but the only thing is that it can penetrate to a maximum to a depth of 3 to 5 centimeter. And most of the time for the therapeutic purposes, we are using RTMS, which is the most common term you must have heard of. And today I'll be also talking about another very recent strategy, which is pattern TMS and therefore intermittent theta burst. Now this TMS is based on the fact that if you are giving repeated sessions of TMS, then it is resulting in activation of long-term potentiation or long-term depression, depending on what frequency you are using, and therefore it is altering the plasticity. And we hypothesize that if you are changing the plasticity, as we know that the brain is a use-dependent plasticity, so if you are altering the plasticity, that should stay for longer period as compared to just giving one electrical impulse and getting a response. So that is what is TMS. So before we moved on to the clinical trials, as a physiologist, we started this work in 2003. We developed a lot of animal models, hemisection, complete, incomplete models, and we studied all the mechanisms of that, and we showed that there is an improvement in locomotor function, there is an improvement in sensory motor function, there is significant reduction in lesion volume and the secondary damage, there is viability of neurons, there is axon regeneration, and the regenerating fibers are passing through the lesion site and therefore making connections. More recently, we have also shown, this paper was published in 21, that not only it is affecting the spinal cord, but at the muscle level, you can see this is necrotic muscle, but the architecture of the muscle was preserved or restored, and there was myogenesis also. Another unpublished study says that if there is a spinal cord injury, there will be cortical reorganization. The homunculus is changed. So we'll be publishing soon. We have shown that after doing the magnetic field stimulation, actually it is trying to restore. So if that happens, we propose that it will be a more long-term effects it will be provided. So we moved our work from bench to bedside, and we got a DBT project in 2020. And because of Corona, we were able to start within next 1 year. We had done a lot of work. So we wanted to study this ITBS. Now why I am talking of ITBS, intermittent theta burst stimulation, because this is actually, we are giving a very high frequency stimulation at a frequency of theta. So that is what is happening in body. So you are trying to simulate that and therefore trying to induce the plastic changes, okay? So we had a sham stimulation group which is placebo, but we also wanted to compare that if what is the effect with RTMS, and then if you are giving intermittent theta burst, whether actually both are equally effective or how do they differ with each other. So we had recruited 66 patients and we were able to analyze 16 patients. So we got ethical, because since this was the first study to be done in India in complete SCA patients, so we got approval only for 15 patients. So we have been able to do that. So this was inclusion and exclusion criteria. And we took only traumatic thoracolumbar region. We avoided cervical, although the neurosurgeons, Dr. Manoj, they said you should include C6, but then the women did avoid that, and because of the reasons of that the patient should be stable. So this is brain stimulation lab which we have in physiology, and we have been doing TMS there, so we have all the advanced setup for TMS. So this was basically the protocol we have given for 5 days, 2 sessions, and therefore 10 sessions. So these were the various patients. They were randomly divided into 3 groups. As you can see, there were females, there were males, and the homogeneous age group. Level of injury varied in the thoracolumbar region only, and all of them after surgery. So I'm not saying before surgery. When they came to the trauma center, they underwent surgery by neurosurgeons or the orthopedic surgeon, and then once the patient got stabilized, we have a physiotherapist, they analyzed, did ASI scoring, and all of them had A. So that's how we recruited them into our study. So before I show the results, I think I'll show you some of the videos of the patients. So after giving 10 sessions, so this girl, she had a injury at L1. Is it working? Yeah. So even after 1 week of therapy, she was able to take few steps. So since they had ASIA, so they all, when they came to our department, to the clinics, they were on stretcher. But after therapy, gradually, we were also giving them definitely the physiotherapy. So these patients were also going to PMR department, and we were giving them extensive rehab program for 1 week along with the ITBS. So this is another patient who, so there was a variability in the patient. So I'm not saying that all the patients recovered at same time. Some recovered at 1 week. Some I think some of the videos are not moving. So, and this patient, actually, he could not move after 1 month, but he was able to stand up and had KFOs or HKFOs. So, if you see this, then there was patients, this I'm just showing after the treatment. So some of the patients, they moved from A to C or A to B or C. Okay. And so most of these patients gradually over a period of time, they were becoming independent, they were able to take care of themselves, and the mobility was being inducted. They were able to stand up or they were able to take few steps. Okay. So walking index, this is placebo group, I mean before the intervention. After we gave the intervention, immediately the walking index improved, and after 1 month also it was on a better condition. So we have now a few patients who are after 3 months, and they have started moving, and they're really, really very happy. And in fact, the sham stimulation group to whom which you had not given the stimulation, they're asking, ki please hame bhi de do. So, and then besides that, there was an improvement in pain scores also, there was depression was reduced, anxiety was reduced, and therefore the improvement in quality of life. So we did, as a physiologist, we did some electrophysiological studies, so we found that the motor threshold, both after RTMS and ITBS, the motor threshold was decreased. Now since they came within 1 to 2 months of injury, and therefore there was flaccid paralysis, so there was, motor threshold was very high because the excitability was less, but after intervention it improved. And the cortical silent period, which basically talks about the inhibition, was also reduced. Now what I want to show here is that we did a recruitment curve. Now this recruitment curve is between motor evoked potential amplitude and the stimulation intensity. If you look at the placebo group, then there wasn't any significant improvement, so it was hardly 0.05, which is 50 microvolt or so, and there was not much change. But after the intervention, you can see there was a gradual improvement, the recruitment of the motor units, and there was a significant improvement increase in the amplitude from say 50 microvolt to 200 microvolt. Okay, so that was very significant, which was seen. So giving us an idea that definitely there is an improvement, and the excitability of the tissue is changing, and therefore the motor units are improving. So although ITBS and RTMS stimulation was highly effective in promoting locomotor recovery, but we are recommending ITBS because the time duration of giving ITBS is only 3 minutes, and especially for spinal cord injury patients, therefore this ITBS is very, very effective, and they're very comfortable, and you can give multiple sessions in a day also. And the motor threshold and MEP recruitment curves can be a sort of prognostic markers, and therefore this can be, ITBS can be recommended as an integral component of rehab program. I would like to thank all my collaborators, faculty members, my mentors, my research students, and the funding agencies who have been funding this project very generously. This is my research group. Thanks to all of you for your patience here.
Thank you very much. Any questions?
Ma'am, the stimulation was a spinal cord level alone, or it was cortical and spinal cord?
Initially, we have now started at motor cortex, but in future we plan to go at spinal cord level also. So this was, we only gave at motor cortex.
So all the SCI patients, the stimulation only at the motor cortex?
Yes.
Yeah, but what is the advantage of motor cortex stimulation?
So basically, if you look at the...
Suppose I have a mid-thoracic spinal cord injury of motor cortex. So you're stimulating the only leg area?
Yeah, we are stimulating only the leg area. So that's why the coil was placed.
I think the stimulation required from the cortex is much higher than the stimulate the anterior.
Sir, actually that is the advantage of using TMS, that we are not giving currents. It's just the magnetic fields. And it is dependent upon, sir, it is dependent on what is the frequency which we are using. So the intensity of magnetic field remains same. If you are using low frequency, then it is causing inhibition. If you are using high frequency, so that is what. So it is just that we are giving 5 hertz, say RTMS. So if you are giving, in this case we are giving 20 hertz RTMS. So that is a high frequency, and that will cause excitation of the motor cortex, and therefore alter the excitability of the cortical neurons.
Physiologically, it is much better to stimulate the area one than stimulate the entire body.
So we are stimulating the leg area. Now
I can do from here.
Sir, actually there is an advantage. So there is what we think as physiologists, that we have both ascending and descending tracts. So it is not that we are only hitting the ascending tracts or the descending or the ascending tracts. Now what we have started here only is motor cortex, and therefore I am talking only of the descending tracts. But what we have planned is that we will be stimulating now also below the lesion, the spinal cord area, so that we can also stimulate the ascending tracts. And then only once the ascending and descending are there is a regeneration, then effective recovery should be there, because what is happening at the spinal cord when we are talking of a movement is the information coming from the proprioceptors as well as the information which is coming from the cerebellum and other brain areas, which is being integrated, and therefore we are providing movement. And secondly, in the spinal cord, like we have been saying, and they have been talking about epidural stimulation, basically we are stimulating CPGs. central pattern generators, okay? And central pattern generators in the spinal cord, even though you are able to induce plasticity, but it is operated at the level of the midbrain. So unless you stimulate the midbrain, there is no effect of stimulating spinal cord, because spinal cord neurons, they are not the pacemakers which are generating the spontaneous activity. It is in the midbrain, mesencephal MLN, which is called mesencephalic locomotor region, MLR. Okay, so it is important that you wish to stimulate the brain, the cortex, which is relaying into the MLR, and then MLR relays into the spinal cord where we have the CPGs. And that is how then we'll be able to generate the pattern movement. So that is my hypothesis, and that's why we started from motor cortex.
I wish to add something to it.
Yeah.
We have been
Stimulating the brain.
by TMS. So
Yes.
it's a presumption that everything has to be stimulated and everything is working under, it has to be taken up to that stimulation level. For the last 1 year, we've been delving to TMS with the knowledge of connectivity. And we have found out it's not stimulating, but counterbalancing with inhibition. Like in stroke, you have to.
Right. Right.
The efficacy of TMS all over the world in all studies has come to 40% only.
Mhm.
The reason is we are stimulating and stimulating and stimulating. We are
Yes.
using ITBS mode.
Yes.
And the CTBS mode is equally important. You know,
Yes.
with the knowledge of connectomics, you can actually find out the fiber track bundles which are not working, which are, if they are underperforming or outperforming. We are not stimulating the fibers, we are trying to balance the networks. Lacuna of the depth of 3 to 5 centimeter, even that can be bypassed. You can reach up corona radiata and internal capsule level if you track the fibers and the connections in between. That's what knowledge of connectomics has helped us in brain injury, in spine injury. We always also tried stimulating at the level of injury and below the injury on the spine, along with TMS, cortical TMS.
Right.
And immediately, post-operative stimulation also I'm talking about. Immediately our main thing was to have more proprioceptive input and more increase in proprioception. So that has improved after TMS at the spinal cord level. So we will wish to work together with you if you allow us a chance, so that we are very nearby to aim.
Yeah, I know. I've seen
Thank
your
you. In
hospital.
interest of time, we'll discuss later.
Yeah, thank you.
Very,
Thanks.
very nice discussion. I now invite Sudipto Mukherjee. He's from the IIT. He's talking on biomedical integration in neurotrauma. Welcome.
Yeah, good afternoon. So, I will try to tell you what we mechanical engineers know about the origins of neurotrauma. And so I'm Sudipto Mukherjee, and I'm the Henry Ford Chair Professor, do some crash mechanics, so we are interested in trauma. There's been a set of experiments. So historically, the had two experiments. They are non-impact, distributed sagittal and planar translations, and or angular motions. So do that. Then there was one series of experiments which were carried out. Well, obviously cadaver experiments, where you vary the magnitude of non-impact distributed sagittal and planar angular motions. And then there is another series which followed after that. So on mice now, where a prolonged coma could be produced by increasing pulse duration of angular pulse and by changing the direction of motion also, from sagittal plane to the coronal plane. So this was, I think, early 70s, I've forgotten the dates. The input direction is important, and with the coronal motion being more important and more injurious than the sagittal angulations. So the blood vessels for ASDH were more susceptible to injury at short pulse durations, and the axons for DAI were susceptible to injury at larger pulse durations. Now, the axon is the locus of kind of brain damage. Most of it happens there, but this is not the only site of injury. So there are other injuries also. And so with this data coming in, so when we started looking at processes which are in there, so one option is that there is mechanical energy which comes into the system, and then it spreads over to axon, dendrite, and all the other structures which are there in there. The other option is that if you go look at the left-hand side, so you have axonal damage, then there is ionic processes, and then you can have oxidative, messenger, inflammatory options. On the right-hand side, what you see is different structures, and then each one of them going through their own injury processes. It's still not clear to us as to which is the formation process. And it's a combination where we look at structural damages and also we are not so good at the biological processes, but there are people who actually take cells and they insult them to figure out what is the injury process in there also. So, so when we look at the engineering statement of that, and it is pretty much based on a lot of 30 centimeter free drop pulses, and we start measuring the accelerations at the vertex, forehead, occiput, right parietal to make it engineering, and then we measure against time. And this is short time durations, milliseconds. So you look at the impact itself. And so we can have some of these processes that we talked about. So we know that there is cerebral concussion, loss of consciousness, we do GCS, and then we also have subdural hematoma, diffuse axonal injury. And we understand there are biological processes, not all of them happen immediately. It takes time for it to process.
AC off.
And the blood vessels susceptible to injury to short pulse durations. So what has been challenging to us is to associate the trauma with the kinematic input. But what I talk about kinematic input is what happens to the motion to the skull treated as a rigid body. So there is rotational motion, there is linear motion, the point of impact and the magnitude of the impact and the pulse duration. Okay. And what I'll show in the end is that it can be unified into something called a theory of rigid body motions, which we don't study in school, which we don't study in our undergraduate education. It comes after that. So some new theory. So when we look at this data and we measure, say, the pulse duration on one side and then the angular accelerations on the other side. So earlier we had the dotted line, which is the Bycroft tolerance line, now replaced by the Hayashi tolerance line. And that has been done based on some primary studies, which I'll again focus on a little later. And then we have, DIAs, the circles with the hollow, the concussion with the dots, solid dots, and the ASDH with the crosses. So the Bancroft line is off, it's conservative on one side, and we can see the Hayashi line is pretty good, except that it doesn't do a good job with ASDH. Well, that is because the term ASDH did not perhaps exist even when the Hayashi tolerance lines came up. So they were not even looking for it, fitting it into that line. And the most important thing is when we look at the crosses, we see that as the pulse duration, so it demands that the pulse duration and the angular acceleration both increase. Now this is slightly awkward because we normally think in terms of energy that if the pulse duration is increasing, you would expect that the injury happens at lower magnitudes. And if the pulse duration is decreased, then the magnitude of the insult must have increased. And so then the next range of models which came in, and it says that, okay, we need to incorporate the relative motion between the brain and the skull to explain this. So, but then what happened is we have these wonderful expressions, right? One is called the head injury criteria, which says maximum T1 integral. Okay, we are quite comfortable with this as equation. And then probability of concussion 1 upon 1 minus e to the power minus beta 0 beta 1 alpha. So pretty much in engineering, when we see a complicated formula like this, we say, okay, that's an industrial hack, but perhaps does not get at the real picture. Okay. So the question is, has the knowledge come down correctly? Well, we know that only linear acceleration is not the driving factor. Only angular acceleration or assessing based on only angular acceleration is not correct. And we have no clue about the reason for progressive damage, especially in DI and these kind of cases. So then in the 80s, or actually the first data got published in 76, a whole bunch of primate studies were done in Japan. So this was done in the Japan Automotive Research Institute, because we want to look at casualties from the automotive side, and they had a huge range of data. So the first set came out in 76, and then they figured out that they cannot explain it. The next set came out in 82, and this data is still unexplained. Okay, and it showed that it's not only the head kinematics, but the impact location and the direction of impact also matters. And so there were other experiments which were done. So in this case, a hybrid free head form was used. So that's a synthetic head form, completely synthetic, and then to mimic drop cases and injury, known injury cases. And the data is quite detailed, but the basic conclusion is that to associate kinematics with the actual injury, you would have to associate location-based differences in tolerances. Okay, so if you look at stresses or strains, you have to admit that, okay, the coronal thing is different, the frontal is different, the lateral different, they have different injury tolerances. The same injury in different parts of the brain will not cause, or the same stress and strain levels will not cause the same observed injury. So then finite element came along, and we can make this, wonderfully nice models. But we are able to predict with accuracy somewhere between 66 and 75% using the best finite element models. Well, we can also build this here. We keep doing it here, also in the IIT. And just the last slide after this. So finally, there is another level of mechanics where we treat the rigid body not as a mass, and then a point about which we describe the motion, which was done by Newton and Euler. But then about 100 years ago, there's new theory which has come. So we start to look at it, and at this stage, we are able to now account for all the Jari tests. So this is new stuff that we have done over the last year or so. So we're looking ahead now to using these methods so that we can now keep learning more about the trauma of the brain, and maybe in a couple of years' time, we are hopeful, before I retire, that we will figure out that if you're injured this way, then this is possibly likely to be the trauma in the brain. So thank you, and that's all I have today.
Dr. Sudipto, my question is that after all these studies, do we also think about ways to prevent injuries, or change the design of the helmet, or give new ideas to the automobile industry to change the preventive measures to head injury?
All of that has happened. I mean, it's changed. So a lot of things have happened. So here in Delhi, we thought that the Germans and the Japanese and the US, they were doing a good job of the cars. So here we have focused quite a bit on pedestrian injuries, and some of the results have trickled down, and it's implemented. There is a pedestrian standard. It's not implemented very well in India. Some of the results have gone into now the German, the way Daimler makes its cars and stuff like that. So yes, things have changed. And some of the work that we have done has gotten into buses and the three-wheeler, because that was Bajaj and that was Leyland. So some of our initial work has gone into the basic front structure and stuff like that. That's what we have been able to do, but we can do more.
And the helmet that normally we wear, is it preventing more of linear motion or sagittal motion? I mean,
it's linear.
Yeah. So
No,
we
not
can't
the
have
way.
designs which can prevent.
Yeah, there is a design which basically is free in rotation. It's been shown to be fairly useful for what are called drop falls. That means you fall from about
Height.
6 feet height onto the ground. Not for the motorcycle impact, where the major one is a linear impact.
Thank you so much. Thank you for sharing. Sir.
Wave dropping method is a very old method by Omaya.
See, we all the time experiment same thing, 30 grams of weight over 30 centimeter for impact. But that experiment has not changed. You should have done 30 grams from 30 centimeter, 100 grams from 10 centimeter, or see, as the mass and velocity increase, there are different type of impact. And this is a model which is very old now. And everybody replicate the same model, 30 centimeter, 30 grams, and one fall. See, we are not considering it is a control environment. Accident is a accidental environment. There are three factors: host factor, vehicular factor, and impact factors. Thank you. That is a control factor, only one static, one is dynamic. So they are not extrapolatable because this all experiment Omaya did about 60 years back. Everybody repeat that. But anything to improve the experiment.
Yeah, so the Jari experiments are rail experiments. So in there, we have a rail so we can control the velocity, and they have done it at different velocity. The direction of impact can be changed, can be made tangential, and you change the pad. So you change the impulse duration. So all of them were changeable, and because they changed it, they got results which could not be explained by the standard results, and when they couldn't explain it, they just put the files aside and put it there. It's only after the 2000s that we started going to Jari. So Anuj Chawla couldn't come today. So we went to Jari, we found this data, discussed with them, took it out, and we started analyzing it. So now there are new results coming out. So we are able to now explain a few things. Please.
They ran rounds in a tunnel, and a train comes like this, toy train, something like that, hit each other. That will simulate a human being coming in motorbike. And another situation, somebody standing or walking. So standing and impact, only one motion. Walking and walking, two motions. Two vehicles at different speed at summation of motions. Motorcycle coming from front, motorcycle coming from back. One is hitting another person from the back. So all these are permutation combination happen in the road. Is that correct?
Yes, we now simulate all of them in finite elements. We have those papers. But we can't do them in practice.
Right. So thank you very much. Thank you. I now invite Dr. Suneet Jindal. He is going to enlighten us on hemostats in neurosurgery.
Hi, a very good evening. All the panelists and all the audience for inviting me here. So we'll be discussing about hemostats in neurosurgery. So as a disclosure, I am an employee of Baxter, and the contents of the presentation, they are on my own views. So we all know that hemostasis and durasealing, they are very essential in both the cranial and the spinal surgeries. And because there's a very limited space that is available anatomically here, so bleeding complications and CSF leak, they always increase the cost to healthcare system. They increase the length of stay, and one of the complications is leading to another complication. So this is where there's a very important role of adjuncts using as to be used as a hemostat. One thing we are clear is obviously the surgical techniques are something that every surgeon tries to take care into account, but there are certain instances where they prove ineffective, or sometimes they are more time consuming. Those are the scenarios where hemostats can be used intraoperatively. So there's a long history of evolution of hemostats, right from the introduction of bone wax in late 19th century to coming to a very new kind of hemostats. These are coming these days. So there are examples like fibrin sealants coming, then there are hemostatic matrix coming, and now some certain patches are also coming. So these topical hemostats, they are normally atraumatic when we compare it with the thermal agents or chemical agents. Then they can be used to control bleeding on table and in the post-op phase also. They minimize blood loss, improve visualization, which is really important for a neurosurgeon. They save operative time. And the most important thing is that they manage patient on anticoagulants. Especially if you look at the neurotrauma cases, here you don't have the luxury to stop the, anesthetist doesn't have a luxury to stop the aspirin or those kind of anticoagulants if a patient is on. So in those cases, they can be really important. And now certain hemostats, they also work as a sealant also, so they can prevent the leakage of body fluids like CSF fluid, decrease post-op drainage and a hospital length of stay. So for there's no ideal hemostatic agent, but hemostatic agent can be evaluated based on their safety, efficacy. They should do what they're meant to do. They should be usable. So when we say about the usability, this is really important because a hemostat, whatever, however good the hemostat is, if we can't deliver the hemostat at a site where you actually want to deliver it, because it's a so complex anatomy, so there should be a proper delivery mechanism to deliver it at a site of application, so that should be there. Then the cost and the availability or approvability within the country. So I was just going through one of the case review papers. So this is from a same neurosurgeon about the hemostat sealants and adhesives. What should be the components of a surgical toolbox? So he has published the same review article in 2008, 10, and 12. So this is very good for postgraduates. So out of that, there was a big table of different kind of hemostats that are available in the market. So now there are a lot of different hemostat sealants available, but how do we make sense out of this? Sometimes it's really confusing for a surgeon also. What should we do in these cases? So we can divide the entire hemostats into two categories. One is active hemostats, one is passive hemostats. So active hemostats are those hemostats which can function irrespective of the patient's coagulation status. Now, patient could be on antiplatelets, or patient could be having some kind of coagulopathies like DIC or maybe vitamin K deficiency, hyperfibrinolysis. So in these cases also these kind of hemostats can work. Now passive hemostats are those hemostats which need coagulation mechanism to be intact because they generally work by activating the platelets. And active hemostats, they are effective across a wide range of bleeding, and passive hemostats, they can work only in a oozing kind of a scenario. So this is how we can divide the entire hemostatic agents. So examples of active hemostatics are like standalone thrombin, flowables like thrombin gelatin, then there is a fibrin sealants, then there are patches. And passive hemostats classical are oxidized cellulose, gelatin sponges, powders, collagens, polysaccharide spheres. So these are the passive hemostatic agents. So everything has its own positioning. So now if there's a patient, especially a trauma patient, where you don't know the history of a patient, so, and you don't have luxury to stop the anticoagulants, in those cases active hemostatic agents are pretty well. So a few of the examples of active hemostatic agents are like FlowSeal, that's a flowable thrombin plus gelatin, TSeal, like a fibrin sealant, and then there are advanced patches now which are called hemostatic sealant patches. So I'll be talking about one of the patch here, that's a hemo patch. So this is a patch which is intended as a hemostatic device and as a surgical sealant in cases where conventional surgical techniques are either ineffective, impractical, or taking more time. So in these cases we can use this kind of a patch, and they can also use to augment the dural closure techniques. So once we are closing the dura, we can reinforce the dura to prevent a CSF leakage in these cases. So pretty simple device. There are two surfaces of the device. So the white surface, that's the underneath surface, which contains a very thin layer of polyethylene glycol, so which come in contact with the blood, and it forms a very strong seal. It immediately sticks over there. Then the body is made from a collagen, which activates platelets and forms a fibrin clot. On the outer surface, you can see there are brilliant blue dots. So this is just to give an orientation to a surgeon, especially in an endoscopic procedure, which is a tissue facing side and which is a non-tissue facing side. So this is a product which has been developed in-house in a Baxter. So there have been more than 400 different prototypes that has been developed. So why this is important? Because most of the products are traded like commodities. They come from one company to another company and so on. So this is an in-house R&D product. So if you look at the mechanism, if you look at the mechanism of action, so there's a polyethylene glycol at the base which reacts with the amino group of proteins and forms a very strong bond over there. And there's a collagen which activates platelets, and further it leads to the common pathway, and ultimately there's a fibrin clot formation that happens. Now, since this is made from a collagen, so when we have to compare it with a collagen for its burst strength, like how much pressure can it hold? Because if we say that it can stop a CSF leakage from happening, then there should be some pressure that it can hold. So this is a different concentration of CSF and blood. So this is 0% CSF and 100% blood. This is 100% CSF and 0% blood. So at every different concentration of CSF and blood, hemopatch that has a better burst strength compared to the collagen. Similarly, as I mentioned, in a neuron have a luxury to stop the anticoagulants. So now this is the solid line is in this experiment they have divided animal into two groups. So one of them were given aspirin and clopidogrel. So the solid line is those animals which were with antiplatelet therapy, and the dotted line is without antiplatelet therapy. In both the cases, you can see within 2 minutes it can stop bleeding in 98% of the cases. So this is a really, this is a very recent registry that was published in January this year. So here they have taken a data of 148 patients where they have used hemopatch. So hemostasis within 2 minutes was achieved in 74% of the patients. Within 3 minutes it was achieved in all the patients. And once the hemostasis was achieved, there was no rebleed before closure in any of the patients. So now one thing more important here is once we see the standard of care these days for CSF leakage, I mean obviously they act as a hemostat, but the standard of care these days is fibrin glue. So now they have taken patients in, there were 65 patients in fibrin glue group and 82 in the hemopatch group, and they were into, the patients were into supratentorial, infratentorial and spinal surgeries. So what we have seen is this, that these kind of patches, they have performed even with a better than a standard of care. This is a Tissile or a fibrin glue in this group. So in both the cases, it has got a lower CSF leakage rate and lower rate of a pseudomeningocele. Similarly, there are some cases, especially when there is a redo case, a patient is coming for a resurgery, where we see that, especially in the posterior fossa, we see that there are more chances that this patient will leak. So in this study, they have used both the fibrin glue and patch together. So there were 22 patients. So out of those 22, there were 14 patients in spine group where ACDF, posterior lumbar decompression or intradural extramedullary tumors were there, and the rest of them were craniotomies. So there were no CSF leakage and there was no infection in these cases. So it's a fairly easy to use device. Just take it out from a packet, nothing to be done. Just apply it over a surface where you want to use it. Press it for 2 minutes. Press it for 2 minutes and just leave it like this. So within 6 to 8 weeks, it will be resolved from the body. So I'll just show how this works. So this is a case of a spinal dural tear. So here, basically after, like in this case, they are using a stapler, but we are after suturing the dura. To reinforce the dura, we can measure the dimensions of the dural tear, and we can take a size of the patch, approximately same size of a patch with 1 centimeter of overlap, press it over there, place it over there and press it for 2 minutes using a dry gauze. And just leave it like this. So within 6 to 8 weeks, it will go away. Similarly, in case of a cerebral surgeries, so this is a case of a posterior fossa ependymoma. So here, basically, after we have taken out the tumor out, so we try to close the dura. So there are small gaps in the dura here, you can see. So after putting hemopatch over this, it acts as a hemostat in this case. Another thing is it augments the dural closure technique, so small gaps it can cover. So it can prevent a CSF leakage in these kind of cases. So you can use multiple patches. You can use multiple patches. Right. So this is how we can use it. Okay. So finally, to summarize, we all know that hemostatic control is really important for neurosurgeons to improve the visualization and to limit the damage. We lose a lot of hours in achieving hemostasis. So active hemostasis, they should be differentiated from a passive hemostasis. That's a really important. And this patch is a soft, thin, pliable patch, which has a dual mechanism as a hemostat and as a surgical sealant, and it can be used in both spinal and cranial surgeries to prevent the dural leakage. That's all. Thank you from my side. Thank you. Sorry. So actually, to be honest, I'm not in a position to answer the price because I'm like a medical advisor for them. But I think generally, I think they are almost of a kind of a similar. In India, we launched it like 1.5 years back.
Hemopatch is new. Durapatch was for long. This hemopatch is new. Yeah, I think they have put up a PEG layer in this. Polyethylene glycol is the newer stuff in this.
That's true. So there are 3 sizes. One is 1 into 1 inch, another is 2 into 2 inches. Approximately, I'm saying in inches. No, it's not that big. So the highest one is 2 into 4 inches.
How much cost? 15,000.
So I think, sir, my marketer would be able to answer. I'm not in a position, to be honest.
I have a different question for you.
Yeah, sure.
See, the mechanism of action of the sealant is mostly based on polymerization of PEG.
True.
Isn't it? Once
That's
it
true.
comes into contact with blood, it denatures the protein and it polymerizes.
Right.
That are the two things which are happening.
Right.
Right?
Right.
So what if we put this inside a, let us say, spongistan,
Okay.
and let it come into contact with blood, it will still polymerize. What is the point of putting a collagen layer above it and making it expensive and
Okay.
susceptible to
Okay.
other reactions as well?
Okay, so one thing is this, in case of a collagen, so collagen access to, there are two mechanisms. One is collagen plain, it won't swell. So one thing, like if you're, the thickness of a patch is 2 millimeter, so the advantage of collagen is that, I mean, it will still stay 2 millimeter only after 24 hours. So this is one thing. This is one advantage of putting a collagen. The another thing is that collagen, the collagen in here, that has an open pore structure. So what happens if you put a collagen over there, and it absorbs a lot of fluid. So once it absorbs a lot of fluid, it also increases the concentration of RBCs and platelets just beneath the, I mean, just beneath the patch. That also actually helps in achieving the hemostasis. So collagen per se doesn't have anything to do with as a sealant, but it majorly has a role as a hemostat only. So like in your case, like if you're putting something else also, we have to take care of the swelling factor also.
Yeah, that is fine.
Yeah, I think it depends on where we are putting it. That's true.
Right.
So if you're putting it like spine or near a nerve root, so in those cases, swelling, I mean, a little bit of swelling can also cause an issue. But for general things, yeah, that's okay. I mean, like if a gynecologist is using in a retroperitoneal space, so it may not make any difference to him.
Right.
Yeah.
Okay.
Thank you.
Right. So we finally come to the end of the session. I hand over the mic to the organizers.
Yes, sir.